we didn't have any randomized trials of adenotonsillectomy, which is the primary treatment of obstructive sleep apnea in children, before the CHAT study. CHAT study confirmed that more children who received early adenotonsillectomy improved both in symptoms, polysomnography findings, and also behavioral problems. It didn't show any improvement, any benefit of treating these children early with adenotonsillectomy for neurocognition. However, it had so many other effects. It improved growth, and also it improved a lot of symptoms and quality of life. So CHAT study showed us that children with mild to moderate obstructive sleep apnea benefit from treatment, and these effects can be measured both by polysomnography and the pediatric sleep questionnaire. For diagnosis of obstructive sleep apnea in children, we need simpler and less expensive methods that's accessible for everyone. One study showed that although children with obstructive sleep apnea who are at lower socioeconomic status, are at increased risk for getting delayed polysomnography or even delayed treatment. So we need to prioritize children who are at disadvantage for having obstructive sleep apnea, and have a good method to screen these children and prioritize for treatment. If we don't have perfect method, these methods need to be either very sensitive or very specific. So either used to exclude obstructive sleep apnea for a test with a very high sensitivity, specificity, or include all the patients that need sleep study with a very high sensitivity, so do not miss any patients. The methods we have now, very good specificity and sensitivity, but they're not perfect for one or another, so we need to use all of these methods together very cautiously, knowing the problems with those, and that we can sometimes miss a patient or overdiagnose a patient. So we need a more accurate method that's simple and accessible to everybody, and of course easy to use for kids, so because we are talking about kids. And treatment-wise, we know adenotonsillectomy is the primary treatment for children with obstructive sleep apnea who have adenotonsillar hypertrophy. But we know even in normal children, the response rate to adenotonsillectomy, so improvement and cure rate, is not very high. It's around 50%, even in normal children. So these children don't have craniofacial problems. They may be obese or young children, and this probability goes higher up if the child is obese or have craniofacial abnormality, or if it's a younger child. So we need to actually decide on a patient basis. If the child has obstructive sleep apnea, consider why this child has obstructive sleep apnea. Is it only the adenotonsillectomy, or if the child is obese and has adenotonsillar hypertrophy, or if the child has craniofacial syndrome and needs maybe non-invasive ventilation, or a combination of therapies. Recently we know about orthodontic treatments for obstructive sleep apnea, and myofunctional treatment for obstructive sleep apnea, and we know which risk factors there are for those children who may be at increased risk for residual disease. So these treatment modalities need to be considered as a combination in the right patient. One treatment modality may not be enough for that individual patient, and sleep endoscopy may be very helpful in that, deciding if the child is going to have a residual disease or if the child is going to need another treatment modality in addition to the adenotonsillectomy.